Hello everyone and welcome to Rad Chat, the first therapeutic radiographer-led oncology podcast. So welcome to podcast number 41. My name's Jo McNamara and I'm joined by my fellow host, Naman Jalka Anderson.
Hi everyone.
A big thank you to our last guest, Dr. Rita Ramadei, who talked specifically around being a consultant allied health professional and also her clinical academic work, equality, diversity and inclusion. So if you haven't had a chance to have a listen, please do go and have a look. So we're pleased to introduce our guest for this evening, Professor Allan Pacey, who will be discussing his amazing career, his research and the impact of cancer on fertility. So hello and welcome.
Welcome, thank you, pleasure. Great to be here.
Oh, thank you. So obviously we now need to say you've just got your MBE, your professorship. Are you going to whip it out?
Well, I can do. The professorship only comes with a new hat, but the MBE comes with a bit more of a trinket. So yeah, I got the MBE actually in 2016, I think it was. And you have a nice little pre-COVID meeting with the monarch, except mine was Prince Charles, which was nice, and we had a lovely chat, and I managed to embarrass him. But you get a thing that looks like that, which I have worn once for show.
Amazing.
So that's the medal itself, which comes in a nice little box. But the bit I wasn't expecting is this, and you get a thing called a warrant, which is signed by the Queen.
Wow.
Somewhere at the bottom, and Prince. Oh, is it signed by Prince Philip? Yes, signed by Prince Philip there, and the Queen at the top.
I was going to say I can't see the Queen's signature on
and
there.
And it just you can see my YouTube lights there. But that's kind of pride of place at the top of the stairs, and it's kind of the official document that says you have whatever privilege that you have, and the privileges are few apart from putting letters after your name. But I do think I can get married or buried in some part of Westminster Abbey if I want to, or so and so forth. So that's a privilege. So it was good. I was chuffed, and actually,
that's amazing. That is amazing.
I still don't know who nominated me. I have a clue, but I think it was in part or big part to do with the work that I was doing with young people facing cancer treatment, cancer diagnosis, and I think that played a big part in the nomination.
Oh, that's amazing. And I love the fact that I was able to get a quote of "whip it out" in a cancer and fertility podcast.
Clever.
Do you want to start by telling the audience a little bit about yourself and your career, your amazing career?
Well, thank you. I've done nothing more in my career than answer email and say yes to most things that came my way, and that was the secret of it, and not being afraid. So I did a general biological sciences degree. I toyed with the idea of going to medical school after that, but decided to do a PhD instead. And the PhD that I did was looking at the biology of sperm. So it was very cell biology focused, and I went away from that. That was at the University of St Andrews, a lovely place, and I had a lovely time. But I got my PhD in 1992, I think it was, and then I got the opportunity to go and study in Nice, just outside Nice, on a Royal Society fellowship, again to do further work on sperm. And I was supposed to be there for 2 years, and then after a year, a job became available in Sheffield, and I applied for it and got it, and it was just a really amazing and incredible time. So the early 90s were when IVF was being developed with gusto. IVF units were springing up. The law had just come into force to regulate IVF. There was a whole kind of regulatory strata in there. Science was exciting. People were looking at ways to improve the efficiency of IVF and fertility treatments and diagnosis, and there were lots of really exciting projects going on. And also it was the point at which sperm banking really started to take off. I mean, we've been banking sperm for men with cancer probably since the early 80s, but it really took off with gusto and with vigour in the early 90s. And I rapidly found myself getting interested in that and getting involved in that, much by probably about 1995. I was in charge of the sperm banking service in Sheffield, And that's pretty much what I did for the next 25 years, along with other stuff, of course, and writing papers and so on and so forth. So that was my introduction to cancer, really, was seeing men after men after men, boys after boys, coming to the clinic to bank their sperm and starting to see what they needed, but also seeing the gap between what they wanted and what was provided. And that was just a really interesting and exciting time.
What sort of research are you looking at specifically at the moment? I know you've published quite a lot of research.
Yeah,
it's really, really good to see.
Probably about 250 papers or so on and so forth. So I have to say, my research career is closer to the end than the beginning now. I'm in charge of 2 medical school departments, so I'm in charge of probably about 300 or 400 staff now. So I spend most of my time doing kind of management things, but in terms of the research that's going on at the moment, I've got students still doing the kind of work looking at sperm that I started life with, and different questions, more molecular techniques. But I've also got a project which is just almost completed, or complete the first phase of, working with a young trainee gynecologist who wants to specialise in oncofertility, and we've had a 3-4 year project looking at gestational trophoblast disease, which is absolutely nothing to do with sperm, but looking to do with cancer of the placenta, essentially, and the impact that has on women. And that is a devastating one, because if you get diagnosed with that early in pregnancy, then your pregnancy, your next chance for pregnancy could be many years away until that is treated. Working with people in Edinburgh and Leeds on better information and resources for men and boys who are diagnosed with cancer and who want to think about their fertility. I'm working with the World Health Organization on global guidelines. I'm working with a group of Europeans on what are the top questions in male fertility at the moment. So I am pretty busy, but my time in the lab doing stuff with my hands, I'm afraid, has gone, which is a shame, because I really do like it. Mm. Mm.
So we do have quite a lot of patients who actually listen to the podcast, and we put out on social media a kind of poll.
Yeah, I mean, it depends, which is a really not unhelpful thing to say. It depends on the cancer,
on the fact that they didn't
depends
know
on where it is,
necessarily
depends
they
on
were at
its
the start
stage,
of their cancer pathway, and they didn't
but it also
know
depends on the
maybe
treatment
what
path that
impact
is
of
then
cancer was
planned.
gonna have on their fertility.
So,
Can you kind
I
of
would
give us a bit of
argue,
a breakdown of what
and this
typically
isn't meant to
you
sound
will see
trite,
in terms of the effects
but
of cancer treatment?
A tumour on the ear that can be removed by surgery probably has very little impact on an individual's fertility. But if we have to start giving radiotherapy, or we have to start giving chemotherapy, and I know this is a Rad Chat podcast, so I'm going to talk too much about chemotherapy, but anything that has the possibility of affecting the brain, believe it or not, or the ovaries or testicles, so in the pelvic region, or the uterus in women, can have a negative impact on fertility. Now, why the brain? The brain is where the control systems are for the production of hormones that lead to sperm production or egg development. So, radiotherapy to the brain can have an impact on the way that those hormones are delivered or how they're produced, and that can have an effect on subsequent fertility. It's different in men and women, because women have all of the eggs that they are ever going to have already in their ovaries, and they lose them slowly at each month when they ovulate. Men produce sperm continuously until they are, pretty much throughout life, unless something stops it from about 13 to probably about 75 or 80. So the effects are different. A lack of hormones from the brain may stop sperm production, and it may mean that the sperm production doesn't restart properly, but it will stop ovulation, but it won't necessarily affect the number of eggs that are there. So in that way, we can provide drugs to women to kickstart the ovaries into action and help them to ovulate more eggs again. Now, it's a different matter when you're thinking about the pelvis, because if we're delivering radiotherapy to the pelvis, then that's where the testicles in a man can get an insult of radiotherapy, and that can damage the sperm production cells, and it can irreversibly damage the sperm production cells. So that means when a man comes out of radiotherapy, he may produce less sperm per unit time than he did before, or indeed no sperm if the dose has been very high. In women, again, it's slightly different, because in women, the pool of eggs is finite. So if the ovaries get an assault of radiation, it can reduce that pool, and if it depletes it, there's no way back. There's no way to make new eggs for a woman where that pool has been diminished. And whether that's a small reduction or a big reduction will depend on the dose of radiotherapy, but also where it's targeted. I mean, there are strategies where you can move the ovaries out the way surgically if that's a risk. The other thing for women is if the uterus gets a dose of radiotherapy, and a high dose of radiotherapy, that can affect its ability to hold a pregnancy to term, irrespective of what happens to the ovaries. So in those cases, it may well be that a woman can get pregnant, but she can't maintain that pregnancy. Now, that happens in very high doses of radiation, but it's an independent effect to any damage to the ovaries. So the effects really depend on what's being targeted, how much it's being targeted, and of course, to some extent, how old you are at the time it's being targeted. So arguably in a young woman, there's more prospects for her to recover her egg numbers, or her egg numbers not to deplete quite to the same level, whereas a woman in her mid-30s or late 30s, it may just actually finish off the number of eggs that are there and thrust her into an early menopause. So you've asked a very good question, your patient have asked a very good question, but actually it's a really complicated answer. And I think to some extent that is why patients get frustrated with doctors, because it's how long is a piece of string sometimes. And of course, the treatment pathway that is begun may not be the end treatment pathway, because things change along the way. And if a patient doesn't respond, you may then have to change the tack, and then that makes it doubly complicated to know what's going to happen. So for all of those reasons, this is why it's imperative that a fertility discussion happens at the very, very beginning, and that due consideration is given to fertility preservation. And in men, that means at the moment banking sperm, and for women it means either banking eggs, or taking a piece of the ovary and putting that in the freezer so it can be re-stitched back into the woman later. And of course, by taking it out of the body, it means it doesn't get that radiotherapy assault. Now, that's about as simple as I can make it. It gets doubly complicated when you've got radiotherapy combination with chemotherapy, because then you've got systemic stuff flowing around the body which goes everywhere. So if you've got a chemotherapy and a radiotherapy treatment option, then that it gets doubly complicated. I think what's interesting is that although that may sound very doomy, actually the prospects for many patients' fertility post-treatment are probably more optimistic than they realise, and probably more optimistic than most oncologists or people involved in delivering radiotherapy realise. So lots of the data out there from big epidemiological studies show that actually contraception is as much of an issue post-treatment as is infertility, of course, depending on how old you are. So that's the Professor Pacey global view of that, and that's about as simple as I can make it.
I think that was a brilliant way to explain it, and actually it really highlights how complicated it is. It's not as simple as it probably has been in the past, where perhaps now we're a lot better at diagnosing patients earlier,
yeah,
and patients are living with or treatable, not curable cancers for even longer than ever before. So something a few patients have asked me before, and I think have reached out via Instagram, is, so with sperm banking and egg harvesting, what is it like? Is it painful?
Sperm banking is surprisingly unpainful, and some men might describe it as enjoyable, at least for a moment in time when they're ejaculating. I have to say, I say that in a trivial way because I'm a bloke, and blokes tend to respond to that kind of humour, I've discovered. But actually, it can be stressful. So just imagine you're a guy, you've got a cancer diagnosis, you're facing treatment in 2 or 3 days, and then some guy, a woman, says you've got to go to the sperm bank this afternoon. You've got to turn up to the sperm bank, fill out loads and loads of forms. You can get a mortgage in less forms than it takes to bank sperm, quite frankly. You've got to sit down with somebody for 3/4 of an hour and go through all of this paperwork, which is just seems bizarre at the time. You've got to think about what may happen afterwards if you don't survive, and name a partner and all this kind of thing. And then you get kind of thrust into this little room, and you've got half an hour to masturbate a sample. Well, it's not performance anxiety is a thing, and we do our best to make sure that it's as easy as possible, it's as straightforward as possible. But men sometimes find it difficult and pressurizing, and I get that absolutely. Yeah. Go on.
Can I interrupt you? Can I interrupt you with a nice story that my husband will love me for sharing? So I know you know that I went through IVF quite a lot of times, and my husband was going in for that pressurised half an hour appointment, and so I decided to take great glee in the fact that obviously I knew he might be using his phone for some kind of reason, so whilst he's in there.
Just text messages,
so I basically went, we went on WhatsApp at that
worried.
stage, so I spent the half an hour
I'll tell you a story.
My friends to say he might need some reassurance and support during this.
We had a bit of a run-in with various people in the hospital. One was infection control, because of course in the old days we used to use magazines,
text messages,
and I had the delightful job of going down West Street to buy the magazines once or twice a year, and the infection control lady said, you can't possibly hand these magazines out to man after man after man, just think about the infection control risk. And so then I said, well, that's fine then, they've all got smartphones, why don't we just open up the Wi-Fi so they can log on and look at whatever it is they want to do? And the IT people saying, oh my goodness, you can't use the NHS infrastructure for that, that's not appropriate at all. So I was having this constant battle with different parts of the hospital over the facility, and then estates got involved, and I said, look, would you like to masturbate in this room? Come on, let's have some nice curtains and some posters on the wall, and let's get rid of the couch and have a nice sofa and some soft furnish. Oh, and it was just, it's one of the delights of running a facility like that.
Surely you would just laminate all of the pages.
Now imagine thinking about all that when you're 13, you got your parents outside.
Yeah. But do you know one of the things...
13, 14, 15, 16-year-olds.
Do you know one of the things that Lee always said to me?
Going, and they'll masturbate in the consulting room. Never mind the little room.
No, they
provided.
were
Others,
some that were laminated.
again, find it
But he
stressful,
did
and part of the
say
skill
one
that
of the
we had
pieces
was
of
it would
information
almost
he
be like a
got
French
was that he had
farce,
to
and
wash his
part the admin
genitals
team would take the
beforehand.
parents away.
And he said
so that
the
when we
sink
came out of
was
the consulting
above
room,
waist
that there was
height.
no parents
And he
sitting in
said,
the waiting
how
room.
am I
when
going to
we could
get my
just, like,
penis
take
anywhere
this
near
lad
that? And
nicely
surely
into the
that's
room
not
and have a discreet
hygienic.
conversation.
And honestly,
And
some of the conversations
sometimes we allow the guys to
we're
produce
quite
on the
local
ward if they're an
family.
inpatient.
But
And again,
it
that
does,
was occasionally
it is,
the nurses
you
were
know,
great,
you're
and they would
absolutely
see me
right.
coming
That
down
whole
the ward,
consideration of the
and
estates
they'd know
is
exactly
really,
what
really
I'd want,
important.
and they'd be in the room with the lad, and they'd say to the parents, "Come on, let's go and have a cup of tea and a chinwag. Let him have some time on his own," without necessarily disclosing that I was on my way to have a discussion about sperm banking because this lad wanted to have it alone, which is his right. So it's complicated at multi-layers. So whilst I make light of sperm banking, and it is a source of certain after-dinner speeches that I can deliver for a fee, it's something that we have to give consideration to, because if you've got 2 days to do it and it's going to shape the rest of your life, we have to make a reasonable stab at getting it right. Now, there could be surgical approaches to that. So your question initially was, does it hurt? There could be surgical approaches to that, and it is possible to take sperm from the epididymis, from one of the tubes that comes out the testicle. It is possible to take sperm from a testicular biopsy, but that is not your first thought, and that is not your first approach. And in somebody facing subsequent radiotherapy or chemotherapy, it's often something that's thought a step too far in most cases. 98% of guys that get referred are able to do it the good old-fashioned way through masturbation. So that's men. What I haven't said there is the options for men or boys who aren't producing sperm because they're too young. And there's a lot of work going on now to look at whether we can cryopreserve pieces of testicle that we can remove surgically. That's not yet mainstream, but there is work going on in Oxford and Edinburgh to look at that, to try and make it mainstream. So fertility preservation for males.
What does that involve?
It involves a surgical procedure. It involves taking a piece of testicle from the boy, and then that is frozen very carefully and placed in liquid nitrogen. I think the big thing that is unknown at the moment is then what you do with it. I think the prospects for being able to transplant that back are probably low, because sperm need to be connected to, the tubules all need to be connected together, and that would almost be impossible. So I think what people are thinking is potentially there's going to be a way to use that piece of tissue to create sperm in the lab for someone, but we haven't quite perfected that yet. So that's research that's ongoing, not by me but by others. So that's males. Females, does it hurt? Well, if we're going to do fertility preservation for females, then we have to be able to capture the egg or eggs that are in the ovary ready to be released. This takes much longer. So in the case of a cancer patient, often time is against you on this. In a sense, what happens is half an IVF cycle happens. So the woman is given ovulatory drugs to trigger her ovaries to produce more eggs than they normally would. And then just before they're about to be released, she would go into theatre, and usually under local anaesthetic, a bit of sedation, she would then have those eggs, for the want of a better word, sucked out with a fine needle that enters the ovaries by going out the top of the uterus. It leads to a bit of pain, both at the time, but also subsequently in the subsequent days. The medication at the time, I think I've never experienced this, but maybe Joe, you want to explain what it's like. But at the time, I would hope the medication nulls the pain. But then in the 2 or 3 days later, I suspect that paracetamol and analgesia would probably take that off. But I would imagine the woman's a bit stiff and a bit sore for a couple of days after that procedure. Is that right? Yeah. Midazolam or something, I would assume. Yeah, yeah. So that is, I guess, something that may put some women off. It may be contraindicated for some cancer types too, but for many women, it is a welcome way forward to preserve their fertility. If there isn't the time, or in young girls and girls of teen years or even below, it's possible again to take a piece of ovarian tissue and to store that in the freezer and keep it safe for such time that she may want to consider having a family.
Yeah, I'd agree with that.
Now, we do have,
during the procedure, I was off my face,
births
and
that
I didn't necessarily feel anything.
obtained around
But
the world
afterwards,
from
it was
frozen
like really
ovarian
severe
tissue.
period pain.
And
Yeah.
that's good news. There's probably 100 births or more now. But so this has moved out from the experimental phase into the real world phase in many locations around the world now. It's limited, I think, not by science, but probably by regulation, in that in order to do this properly, you've got to have a tissue bank, a regulated tissue bank close to the place where the tissue is going to be taken. You can't just put ovarian tissue in any old freezer and keep it there for 20 years. It's got to be, so there's a different level of regulation involved in this, and that's I think what's limiting it in certain parts of the world. For women that have had eggs frozen, then the data on egg freezing is really, really good, and really using frozen eggs, we can almost get a woman back to almost natural fertility again, or at least comparable with cycles of IVF. Of course, the limiting factor there is how many eggs you have. Hopefully you would have 10 or 12 eggs in the freezer. If the ovarian response has been poor and you've only got 1 or 2 eggs, then you really do reduce the chances of that being successful. And of course you don't have time in a cancer cycle to repeat it, because you've then got to get on with treatment. If this was being done for social reasons, for example, you might do a couple of rounds of this egg freezing technique if the response was poor. So the pain involved is really at the outset. It's involved at the outset, the process of, for want of a better word, sucking the eggs out of the ovary when they're close to being ovulated. And that isn't for everyone, but actually it's bearable. And so I think for many women, they think it's something worth doing.
Where can people, so any maybe prospective patients or even relatives, access information about all of this?
Yeah, there's a number of resources around. I mean, I'm assuming your podcast goes around the world. If you're in the UK, there is the first port of call would be the Human Fertilisation and Embryology Authority website, hfea.gov.uk, I think, and that is our regulatory body in the UK, and they have some great resources about what can be done, but also where it can be done. Now, hopefully, the team involved in treating that cancer will be able to refer to the local place. But if that hasn't happened, or the patient wants to make a different choice, then there's a Find a Clinic finder on there, and you can put in your postcode, and it tells you where the nearest clinics are. So that, if you're in the UK, that would be good. If you're in Europe, there's information from the European Society for Human Reproduction and Endocrinology. Embryology, ESHRI. They have some resources out there, but there's also some European oncology places that you will know more than me, and maybe we can put some links up or something of links to resources. In America, there's ASCO, is it? They have some professional resources as well as some public resources. So it really does depend where you are around the world. But they're the 3 main places that I think I would recommend, and I'll hope you put some links together after we've finished this.
Absolutely, yeah. We'll link everything with the podcast. It'd be really beneficial. We've had quite a few patients and even healthcare professionals kind of contact us just about this podcast as well. So I know, Allan, you touched earlier about what kind of happens after not just radiotherapy, but after cancer treatment, and actually the prospects aren't as bad as some people think. What sort of things can cancer patients or even their relatives or carers expect, especially if they want to go on to conceive post-treatment? And how long might you suggest having to wait as well?
Yeah, the waiting one is important. So you get different answers from different people, so be aware of that. From what I see, you should generally wait for about a year, both for men and women, before you try and conceive, and that's for a number of reasons. In terms of gamete health and the health of the sperm that are produced after treatment, or the health of the eggs that are produced after treatment, it's necessary to wait for things to settle down. So in sperm, there is evidence that you see chromosomal abnormalities increase in the few months after treatment. In eggs, I think the same kind of data's there. So you kind of need physiology to settle down. So I think for the first year, contraception is really key. There's also the added complication for women that if there was to be a relapse within that first year, and when a relapse when the woman is pregnant, that then makes it doubly complicated for her, because then you're going to have to think about how you treat her cancer and protect the baby at the same time. So there's a reason, if you're a woman, to wait and get the green light before you try for a pregnancy. So that's the general rule. Now, if you're trying for a baby and you want to get on with it, if you're a man and your partner is fine, then there's no reason why she couldn't try with the frozen sperm whilst you're still in treatment or recovering in that first year. I would argue that you ought to think sensibly about that, though, because pregnancy and looking after a newborn is a job in itself. And if you're still feeling a bit unwell as a partner, as a male partner, or you are facing a possible relapse or second round therapy, then maybe that's something you should wait. But of course, that will be dictated by partner's age. If partner's age determines that pregnancy should be started quicker, then maybe it's a risk worth taking. If you're a woman, then again, it's an age. It's indicated by age. If you're a woman in her 20s, and you want to have a family, then you've got time to wait, and you've got time to wait to try naturally after that first year of hiatus. And you know, given that many women don't even start to think about having children until their early 30s, you know, being in that position in your early 20s is potentially a luxurious position to be, as long as we're not worried about an early menopause. But of course, then if you've frozen your eggs, you've got those to fall back on as a second line therapy if natural conception doesn't work. And if you've frozen ovarian tissue, then you've got that to fall back as a second line therapy as well. It's interesting in the frozen tissue studies, and I'm thinking about the data from Edinburgh now. Edinburgh had some really rigorous criteria about who could access ovarian tissue cryopreservation. So you had to be really looking at some hardline therapy for the cancer treatment before you even got into their trial. And now, 10, 15, 20 years later, when they look back, the majority of patients that they froze the ovarian tissue for still got pregnant naturally, which is great. And they've never needed to use it. So that just shows you that trying naturally, once you've waited that first year, is not a bad option, but it is something that's determined by female age, both for men and women. I've had more consultations with couples where my advice has been, go home and have a go, than it has, you need to go to the IVF unit. And the number of patients that come back and say, my goodness, that was the best advice anybody's given me. Because I think there's a fear factor about trying to have a child naturally after cancer treatment. And an understandable fear, because people are worried about the quality of the sperm if they're a man, or the ability to carry a pregnancy to term, or even get pregnant in the first place if they're a woman. And so I think a bit of reassurance is not a bad strategy for people who want to try for a family after cancer treatment. Of course, if you're older as a woman, or you're a man and your partner's older, then that's when to seek medical advice. And I would say, you know, if you're in your 30s, you know, that's the time to go and get some tests done, because we can easily test sperm. We can fairly easily test female fertility by doing some ultrasound or doing some hormone checks. So you can get a fertility MOT post-cancer treatment, and that should hopefully guide the patient as to what they should do, whether they should go for it or seek a referral for some assisted reproduction. Mm. 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 Yeah. So the first thing to say is that the NICE in the UK we have this, or in England and Wales, and we have this thing called NICE, and that makes it very clear that if you're a cancer patient, the fertility preservation part at the beginning should be free, regardless of all of the things you mentioned and regardless of previous treatment, because the medical system is doing something to you that will lead to infertility. So the least it can do is preserve.
Alan, can I just ask, is there any eligibility criteria around IVF when you have a cancer patient? I know from my own personal experiences, the criteria that we did or didn't meet essentially meant that we had to pay for all of our assisted fertility and assisted conception. But where does that stand for cancer patients, and are there certain criteria that they have to meet? I'm just thinking about maybe patients who smoke or are maybe overweight. Some of the things that typically you would get told to consider if you were hoping to get NHS funded assisted conception.
It's much more even-handed about things. I'm less clear about the rules in Northern Ireland, but in England and Wales it is postcode lottery driven largely, and it depends on many factors such as the number of previous children in the relationship, whether or not they're in the house or not. So a woman who's had cancer may not have access to IVF if her partner in some places has a previous child, even though that previous child may be with the child's mother. So it gets very complicated. There are age limits. In some places there are BMI limits. In some places I have seen there are limits on whether or not a woman smokes, and so on and so forth. It is absolutely, totally confusing. And it's unfair, and it makes it difficult for people to access treatment in a timely way. Now, it's not for the oncology team to understand all that. That's where you do need to have a conversation with a GP, or have a conversation with a fertility specialist at secondary level care in your local fertility hospital, and they should be able to unpack it for you. My advice has always been, if it is not working in your favour, before you spend your own money, write to the CCG and complain. Write to your MP and try and get some leverage here, because I think it's deeply, deeply, deeply unfair for people who've gone through cancer treatment and had their materials stored to then have to face this battle. Unfortunately, many people have to pay for their private IVF or their private fertility treatment, cancer or not, and that is a difficulty that we have in the UK. Of course, in other parts of the world with insurance-based systems, there are, in Australia, for example, they have a strong insurance-based system where I think it pays 80% of the costs. North America, fertility is increasingly being covered by insurance. In Europe, I think it's a mixture of arrangements, a lot of private medicine in many parts of Europe, although in some countries, Holland, they have a strong national health service that's run in a similar way to the UK. So it really, really does depend on where you are in the world. I think one piece of advice I need to give is please, if you have fertility material stored, sperm, eggs or embryos, keep in touch with the clinic. There are strict rules about how long that material can be kept for reasons of consent or reasons of law. And the common message that I get from all over the world from fertility professionals is that we bank the stuff and then we never hear from the patient again. And they may not hear from the patient again for good reason, because they've had their family and they're happy and they've moved on and they're pushing prams and going to centre parks or whatever, and that's great. But that leaves a dilemma for the place storing that material, and they can't then discriminate between people who need it and people who don't. And sadly, there are too many stories of material that's been removed from storage and destroyed because the consent periods have elapsed and the facility thinks it's following the consent procedure, and then 2 weeks later the person walks through the door. And I've had that very experience, and it's not a nice place to be in. So please, 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 if you're a patient listening and you've got material stored, please do keep in contact. A phone call, a letter, responding to whatever they send to you, keeping your address up to date, and all of those things are really, really important. Yeah. Yeah. It is. And it's really complicated. And again, that's one of the things I spent a lot of time doing in my 25, 27 years. We would have regular annual conversations with men and women and their partners to say, look, this is what we've got. This is what it means. This is your consent period. What are your plans? Don't feel pressured, but we have to have this conversation. And I felt it was like life coaching, actually. I think one of my roles was kind of doing that fertility coaching thing over a long period of time. And actually in my new job in management now, I really do miss that kind of clinical contact, because you saw people's lives develop, and we had tears of joy and tears of sadness in those consultation rooms often.
It's also really important to note as well, Alan, on
lots
that
of emotion,
sense
I'm sure.
that when you've had the material taken as well,
Alan, you touched
to just ensure
quite
that it
briefly
is
about breast cancer
appropriate,
and
because I
fertility.
just speak from
Just
personal
wondering,
experience,
just in case anyone's
where
listening,
we were under the illusion
how does hormone treatment,
that
so when
Lee
patients
had
are on
sperm
long-term
banked
tamoxifen,
and I had
letrozole and
eggs banked,
anastrozole,
and
post-radiotherapy,
actually
how does that
Lee's
affect
sperm
fertility?
wasn't
And
good enough quality.
as you said about maybe waiting a year to
but
try
we were
naturally,
never informed.
how
So
would
when
that affect
we
them
then
if
a
they're
year later
perhaps gonna be
decided
on
to go
tamoxifen
for
for 7
treatment,
years or 5
we'd never
years?
been informed
Yeah,
that
that's
actually
a
he
good
didn't have any.
question, and to be
So I
honest,
think that
I've
is
not
just
really
that line
used
of
that
communication, isn't it?
I think this is one where you have to have a consultation with a fertility specialist who can take all the factors into account. Some hormone therapies might suppress fertility temporarily. I don't think that's the case with tamoxifen, but I do know that some do. So that's something to bear in mind. But I think some of these longer term therapies are troublesome, actually, in terms of understanding what to do. And I think that's where the evidence is slowly emerging. And I do know that for women with breast cancer, I think one of the fears is, if I get pregnant, will my tumours return, or will I relapse because of the hormones that are in my body? But from my recollection reading of the literature, actually pregnancy is surprisingly protective of future relapse for reasons that I don't fully understand. So, but I think that's where a very specific consultation is needed, perhaps with a joint oncology team and reproductive medicine team, to actually go through and unpick that. I do recall that kind of treatment holidays to allow people to have pregnancy are very common, but the specific circumstances, I think, have to be worked through.
Interesting, yeah. And obviously, if there's any literature that we'll definitely link it in with this, because I think it's with quite a few. I think I've seen lots of breast cancer patients my age or younger at the moment. I think it's something that research it's interesting that people are looking into it, because it's quite important. So obviously we're coming towards the end, Alan. You've touched on a few brilliant top tips, but we always like to end with sort of top tips for general public, or patients that are listening, students, anyone really. What would be a couple of things you might give for anyone listening around this area, so fertility and cancer?
I think I think the biggest top tip that I would give to patients and professionals alike is have an early conversation. Make sure it's part of that initial discussion. It's a difficult discussion to have at the beginning. I can understand in those early planning meetings to then throw in fertility might seem like an added complication. But it's often not possible to revisit fertility preservation once treatment has started. So it's vital that you have an early consultation and that you assist the patient to make the right decision for them, or if you're the patient, that you make the decision that's comfortable for you, and go into the treatment knowing that you've made the best decision possible. So early conversations are important. Post-treatment, I think it's post-treatment conversations are important too. I've met too many people that have put their head in the sand as patients. I've met too many professionals that didn't know what to do post-treatment and didn't know where to refer the patient or what to say to them. And I think, maybe not on day one of the post-treatment life is that when that conversation should happen, but the oncologists and the people involved in delivering that treatment will have a much stronger relationship with the patient in those early years than the people in reproductive medicine will have. We may have only seen them fleetingly for that fertility preservation appointment if that's what they decided to do. So I think for oncology professionals, make sure that fertility is picked up in those subsequent follow-up conversations over, say, the first 5 years, and that then at the right moment you signpost that person back to fertility if that's what they want to do. And that's what I would urge, because I think all too often it's forgotten. I did a great on stage conversation with a guy a few years ago who we went through this, and he'd banked sperm and he'd survived his treatment, but then he never had any thought about what he was going to do with his banked sperm. And he sat on stage in front of 400 kids and said, I could have used Google like everybody else, but it just didn't occur to me. And it was just the fact that we sat down and had a conversation. I said, well, what are you going to do with this stuff? And he said, well, what can I do with it? And I said, well, you could have some infertility treatment if you wanted. And he said, would they do that for me? And I went, yes, of course they would. And we got him in the IVF unit, and he had a young son as a consequence. And it's because people don't join the dots. And why should they? They've been through a lot. So let's help people join the dots and have those conversations so they can be pointed in the right direction at the right time.
Thank you.
Bye-bye.
Oh, thank you so much. That's been amazing. And I know that lots of people listening would have really benefited from your experience. And we will definitely put in lots of links to literature and support for anyone listening who wants to find out more. And obviously, Professor Allan Pacey has lots of literature and research out there, so you can, of course, Google him and access all of his literature as well. So thank you all for listening to Rad Chat. Your hosts today have been myself, Jo McNamara, and Naaman Jolka Anderson. A huge thank you again to our guest, Professor Allan Pacey, MBE. Head over to our YouTube page to see our live recording of the podcast. And if you're utilising this podcast for CPD purposes, consider the reflective questions posted along with links to the resources and literature we've discussed. And to receive your accredited CPD certificate, please complete the Google form linked with the podcast. So our next guest to feature will be Dr. Emma Hyde, who will be discussing personalised care within diagnostic radiography. So thank you all for listening. Thank you, of course, to our guests, and thank you.